Hi, everyone. This is Robin Carlson with Stratus Health. Welcome to the first session in our 3 abstraction training sessions. This one is on the EDTC Abstraction and Submission training. Joining me at Stratus Health is Jody Winters. I'm sure that you all know her from her sending you emails, but she'll be helping me today kind of monitor the chat and helping me with any technical issues, because no matter how many times I do this, I still seem to maybe have some. Just want you all to know that if you haven't been on a training with me before or a call, I tend to be pretty informal. This is a situation where you need to mute yourselves, but if you have a question while I'm giving the presentation, feel free to unmute or put it in the chat. And Jody will help me monitor that. So sometimes it's easier to take questions as you go along. So pretty much what we're going to do is just first, in a second, I'll introduce Patrick Merrigan, and then he'll talk about the MHA portal and how you submit the data. Then I will show you where to find this EDTC Specs Manual. Hopefully everybody knows where that is, but just in case, we'll go over that and then go over the manual. And there should be plenty of time for questions, and we'll have a little wrap up at the end. And everybody's going to get a little assignment to do. So again, I'm Robin Carlson. I've been at Stratus Health for over 20 years now. And my real main job is helping critical access hospitals with submitting their core measures data, abstracting and submitting their core measures data. I do it for you guys in the state on a personal one-on-one level. And then my other job is with the Arcata team, where I kind of do it on a national level. So that's me in a nutshell. We've got about 25 participants again, so please feel free to speak up. We just, this needs to be for you guys. And let me just say, we're not doing this because there's something new with the abstraction. Okay. The last new information about EDTC was back in a couple of years ago, when we went from the 28 data elements to like the 8. So there is nothing new. We're not doing it for that reason. We're doing it because it seems like there's been a lot of turnover at the hospitals, and we want to make sure everybody's on the same page. We still have a few misconceptions about the population and a few things, and we just want to clear all that up. So what I'm going to do now is stop screen sharing and turn the session over to Patrick Merrigan from MHA. Some of you guys have probably worked with him before. If you had a new person coming on and needed to know how to use the portal or had some trouble with the portal. But I will stop sharing now. And Patrick, thanks for joining us.
Okay. Hey, Carl. So here, I'll just start sharing my screen. Grab the right one. Okay, so like Robin said, I'm Pat Merrigan. I work for the Minnesota Hospital Association, and we kind of manage the ED transfer submission page. And so it's a pretty simple process. If you don't have access to the portal, for instance, you can just go to this website, portal.mnhospitals.org. On there, you can see, you can contact Jacqueline Rowland or myself. We can go ahead and give you access and get you set up with the necessary rights. So basically, you would just go to portal.mnhospitals.org. You would click on My Applications. You would log on with the information that we give you. It's generally going to be your email address. And so then once you log in, it'll kind of bring you back to MHA data portal. And if you have access to any of our other applications, patient safety, QPS, surveys, anything like that, they'll show up here. But we're just logging into the ED transfer site. So that's one of my options here. And we'll just click on that. That'll bring me directly to the ED transfer site. Kind of have a listing of the submission dates as kind of your first view. There's some resources over here that you click on that'll take you off to the Stratus website. And then basically you just go over here in the upper right-hand corner where it says enter ED data and click on that. And it'll show you all of the data that you've submitted so far. This is just the Minnesota Hospital Association, so there's only 2 quarters in there, but they'll all be there. And you can export this data too if you want to see it or use it for your own purposes. You can delete data, you can edit the data, or we're just going to go ahead and add a new quarter.
Walmart.
And so a pop-up window appears. You know, we're entering for the Minnesota Hospital Association. I guess I should mention that. So if you have access to more than one facility, they'll show up in this drop down here, and then you'll just select them. And so I'm entering for the Minnesota Hospital Association. And so that, you know, it shows that right there. It gives you a drop down list of all the report periods that you have not reported for. So, you know, Q1 2020 isn't listed here because we've already reported for that. And so you would just select, you know, the current quarter that you're reporting for, and start entering your data. Each one of these hyperlinks has kind of a help or description on it to, you know, just to kind of help you out, match up with the worksheet that you get from Stratus. And so you just start entering whole numbers in here. You know, you can't put decimals or anything like that. It's just whole numbers. You can use the up and down, or you can just, you know, type directly in. And you basically just enter the data. Kind of calculates the percentages for you as you go on. If you, for instance, you know, make a mistake, say, because the total number of patients has to be your higher number, you know, if you accidentally enter a higher number, we'll warn you about that. And you can just quickly correct that error. And then you basically just click save. And gives you a little pop-up that says your data has been saved, you know, for the quarter and year that you've submitted. You can now see that data here. You can go ahead and edit it if you've noticed that there's been any mistakes made. And it also sends you a confirmation email, you know, letting you know that your data for that quarter, so for instance, in this case, Q3 2020 has been submitted. And really that's about it. I mean, there's a state trends report that you can look at that kind of aggregates the data. Doesn't provide your data specifically, it's just aggregated at a statewide level. You know, if you want to look at that report. But other than that, that's really about it. Unless there's any questions or anything.
Does anyone have any questions for Pat? You can unmute yourself or write it in the chat if you want. I'm not seeing any in the chat.
Okay.
Last chance for questions. Okay. Pat, thanks a lot.
Sure. Sure.
Appreciate your help. You can certainly stay on if you want, but you are free to leave.
Okay, thanks, Robin. Take care. I
Yep,
will-
thank you
will-
again.
Sure. All right. Bye-bye.
Bye-bye. Okay, everyone. So we're going to get started. I think the first thing, hopefully everybody knows where to find the manual, but just in case they don't, I want to show everyone where to find the EDTC Specs Manual. So going to share my screen. And forgive me, but I'll always keep asking. And Jody, maybe if you can answer, let me know if you're seeing what I want you to be seeing. Is this the Stratus Health main page?
Yes, we can see that.
Okay, thank you. Someone needs to answer me. All right. Oh, someone is in the chat. Oh yeah, thanks. Thanks, person in the chat. Okay. From the Stratus Health main page, and remember, the EDTC manual, it's not a CMS manual. Okay, it's not. The EDTC measures aren't CMS measures, so that's why it's not housed on any of the CMS, excuse me, any of the CMS sites. So the Stratus Health page, you're going to go under current initiatives. You're going to scroll down to ARKITA. Okay, that's the MBQIP program. The MBQIP program is under ARKITA. Stratus Health is the Rural Quality Improvement Technical Assistance Team for the nation on the MBQIP measures. So that's why this information is housed here. On the ARKITA site, scroll down to Emergency Department Transfer Communication Measure. Here's information about the measure in general. And then here you've got your manual. Here would be your Excel tool. And there's a recorded session on how to use that. And but here's your manual, which is what we're dealing with today. Okay, and people, can you see my manual?
We can, Robin.
Okay, thanks. All right. And again, you guys, if you have questions, feel free to put them in the chat or unmute yourself and speak up. So the last time this manual was revised was in October of 2019. And again, that was when we went from the 28 or so data elements down to the 8 that we have now. It's not measures. I mean, even though there's the 8 data elements, there's really just an ED transfer communication quality measure, because either, you meet them all, a record, either it passes because it has all of these data elements met, or even if one isn't met, it's not, if just one isn't met, it's not met. So it's like an all or none measure. I will let you read the background of the measure, but just remember, this measure seems to either be like people really love it and they understand the meaning behind it and think it's very useful, or they kind of hate it. There doesn't seem to be a middle ground. But I think the main thing to keep in, I don't think, I know, the main thing to keep in mind is what's behind the measure. And if you always think about the fact that it's patients who were seen in your ED and then are going to another facility. And where they're going, the people at that facility who take care of them, who assist in taking care of them, they need to know what happened when these people were in the ED. Why were they there? Were there medication changes? Were there, were there labs done? What was done there? That information needs to go to where these people are going. So let's start out here with like the biggest, tends to always still be the biggest issue is the population. Okay, who do we have to do? Patients seen in our ED, which ones do we have to abstract for this measure? And it's defined by those patients admitted to your ED who were then discharged or transferred or returned to these facilities. Now, yes, I know it's called the ED transfer communication measure, but it's not just transfers. Okay, you've got to get out of that thinking of we transfer. it's all about where is that patient going after they leave the ED. So whether you use the word, that they were transferred, or whether you say they were discharged, or whether they're just returning to where they were before, that doesn't matter. It's the site, it's the facility that matters. So those patients that should be in the populations are one that are going to leaving your ED and going to any acute care facility. If it's a cancer hospital or a children's hospital, or if it would be another critical access hospital. And that happens, in other states. I don't know so much that it happens in ours, but, some in some states, maybe they're seen at a relatively really small critical access hospital and get transferred to one who has maybe more services. So that's why we have that in there. If they're going to a VA hospital, if they're going to a PPS hospital, any acute care hospital, okay, they're included. If the patient is going to a hospice facility, so a facility that is hospice. And then the big category, because we don't list every category, but under other healthcare facility, okay? So if they are going to an extended or intermediate care, long-term care, if they're going to a nursing home, these are the big ones, okay? And it does not matter if they live at the nursing home, okay? I understand that hospitals consider that, a lot of them, maybe all of them, consider that as the patient is discharged home. And so that's what maybe they have as their discharge code or their discharge status. I'm not saying that that is wrong in any way, shape, or form, but for this abstraction, they are being transferred or discharged or returning to a nursing home. And a nursing home is listed as one of the inclusions. Okay, so again, you look at the facility, and it does not matter that they live there. Okay, they are going to a nursing home. That's included. If they're going to a psych hospital or a rehab facility, skilled nursing facility, if they're going to swing bed, it doesn't matter if it's your hospital swing bed. A transitional care unit, okay? Any of these facilities are included in the population. And this is not like optional, okay? It's not like you can decide, well, we're not going to do those. We're just going to do this for transfers to acute care. No, this isn't like a pick and choose population. This is your population. Okay. To do this correctly, it should be all of these patients. Now, again, I'm not going to pretend that it's easy to figure out the nursing home ones. I know, in fact, it's not from talking to some of you guys, because your hospitals consider that as a discharge home. And I'm sorry, I can't tell you the best way or even any way to be able to pull a list of those patients. Everybody's system is different, so there's not one way that we can just say, oh, this is how you would get these patients. It's unfortunately, it's however you are able to get a listing of these patients, but it is not correct to just exclude them because it's difficult to get them in the list. All right, so that's your population. What are not included, so your exclusions, would be anybody who left against medical advice, if the patient expired. Home for these purposes, okay? For this EDTC abstraction, home would be if they went home to their house, okay? If they went to assisted living. A board and care, or a homeless shelter. For this abstraction, going to jail or prison. If they're going home and they have home health services, or they're having outpatient services, but they're not, they're going home and they're just having these services, that's not considered an inclusion. That would be excluded. If they're having hospice at home, they're at their home and doing hospice, that's an exclusion. And then observation status. If they're seen in the ED and then go to observation, those patients would not be included. That's an exclusion. So any questions about the population? Okay, and again, nothing is this is new. So hopefully you're not hearing anything for the first time. But again, got to reinforce nursing homes are not going home for this. And try to forget about that discharged or transferred. It's where the patient is going more than whatever terminology you use here. Okay, sample size requirements, it's a minimum of 45. Okay, so for the quarter, it's a minimum of 45. You can do all of your cases that meet the population. You could do 50, you could do 60, you could do, you know, any number you want. The minimum is 45, unless of course you don't have 45 for the quarter. Okay, if you don't have 45 that meet that population for a quarter, then you do all of them. Okay, we just say a random sample. We don't tell you how to pull a random sample, but what we just say is, you know, we're trying to get like a cross section of your ED. So, you know, different staff, different shifts, you know, don't always do the same day or don't always do the same shift. But other than that, a random sample, however you would choose to do it. And sometimes there's been some confusion that people weren't thinking they could only do 45. But again, it's however many that you would like to do, unless of course you don't have 45, then you do them all. And the measure calculation, that's where we talked about it's an all or none, okay? To meet the measure, the patient has to have met all the 8 data elements. So there has to be documentation that all of the data elements were sent to the receiving facility. You know, I think we look at, for a quality improvement standpoint, it's easier to look at it as the individual data elements, because some people might be great, you know, and always be 100% on certain data elements, but might fall down on 1 or 2 of the other ones. So I think when you're looking at this as for quality improvement, that's where looking at the individual data elements really come into play. Okay, so for this abstraction, this is kind of our definition of sent. Okay, and again, remember what we're talking about here is that these data elements that we're going to go over, that there was documentation in the record that they were sent, meaning one of these requirements, to this receiving facility. So for all data elements, the definition of sent includes the following documentation requirements. If it's documented that a hard copy was sent directly with the patient. So I don't know, you know, I'm old school back, you know, like I told you, I've been working at Stratus forever. And back when we started this, I mean, it was always copy was made and sent with the patient. And you know, there might be some places that still do that, maybe a lot, I don't know. But that's, you know, again, that's as maybe simple as it needs to be, is that there's documentation somewhere in that ED record that, you know, the ED record was printed and sent directly with the patient. That would meet the requirement. If there's documentation that it was communicated via fax or phone within 60 minutes of patient departure. Okay, so if there's documented somewhere that, you know, pages were faxed or the record was faxed and sent to the facility within that 60 minutes of the patient leaving, or communicated if there was a phone call, but it has to be documented that the data elements were discussed. So just the fact that there was a phone call, that's not enough, because you don't know what was discussed. And remember, it's all about I know I'm going to sound like a broken record, but this is what you have to remember. This is the bottom line. These data elements that we're going to talk about, is there documentation that that information was sent to the receiving facility? Okay, and within the 60 minutes. Now, if the hard copy goes directly with the patient, it's going with the patient. So it's whenever the patient gets there. I mean, I had a question one time because a patient was being transferred and it was like 2 hours away. Well, it didn't meet the 60-minute guideline, but the patient wasn't there either. It got there when the patient got there. So that's why it doesn't say the 60 minutes with the hard copy. It's getting there when the patient gets there. But for everything else, for this one, if it's fax or phone, it needs to be done within 60 minutes of patient departure. So if you've got a shared EHR, okay, now, your record isn't going to document we have a shared EHR. It would be great if it did for this. I mean, it would make abstraction a lot easier, but we know that's not the case. So if you have a shared EHR, what is kind of your responsibility is knowing, does that mean data entered into the system is immediately available? Okay, so when your nurses or your physicians are entering data, is that data immediately available to that receiving facility? Okay, I mean, it's got to be there within that 60 minutes of the patient departure. If it's there the next day, if it gets there the next day, that's not meeting the requirements. So this is an issue kind of, with the EHR, it's on you. Not like there isn't a lot on you, but it's on you as an abstractor to know what exactly does that mean. Okay, we might have a shared EHR, but are these people going to be able to see it? If they're getting transferred to wherever, can these people see it? So just having an EHR, you need to maybe do a little bit more investigation. Is the data immediately available, and are the right people going to be able to see it? Okay, and I can't really help. I can't help you with that because, again, everybody's system is different. So you as an abstractor, knowing what's behind all this, okay, that these data elements are getting to this facility, are you meeting the requirements with your EHR? Does that make sense? Anybody have any questions about that? And again, I'm not trying to say that it's easy to figure out this stuff. I'm just kind of I'm just explaining how the measure works, how the abstraction works. Okay, I don't see anything in the chat. So if there's no questions, I'll keep going on.
Robin?
Yes.
This is Veronica from Rainy Lake Medical Center. And I apologize if you said this and I missed it, but with the shared EHR, one thing like I've been paying a lot of attention to now, because we just switched to Epic last year, is like sometimes we have a shared EHR, but like the provider didn't sign their note until like the next day. So then like I would be throwing those or saying like those didn't meet like the elements, because if the provider didn't sign the note, technically not like a finalized record. Is that correct?
I want to get to that. I'm definitely going to get to that when we get to the provider note. Okay.
Okay.
So if I don't answer your question and you have more questions, wait till we get to that provider note data element. Okay.
Okay. Thank you.
Yep. And it's a great question because a lot of people are having it. So we need to have a discussion about it. Again, so this one is talking about, it's an all or none. Okay. Either all of the data elements are met and then that patient meets the EDTC measure, or they don't. So I will let you look at that as we go to the data elements. Home medications, okay? So, and we always list what sent means on every one of the data elements. Again, hard copy sent directly with the patient, communicated within 60 minutes, immediately available, shared EHR. So, does the medical record documentation indicate that the patient's current home medication list was sent to the receiving facility? Yes or no? If the documentation indicates a patient is not on any home medications, that would be yes. If it says home medications are unknown, that would be yes, because obviously there was no way for you to know. If the patient isn't able to respond, that's a yes. But we want current home meds. Okay, so pulling up a review in the patient's current record, in this current ED record, pulling up a review from the last time that they were in the hospital, that's not good enough. If you pull that up and then it's gone through and saying, oh, patient isn't on this anymore, if it's been reviewed and updated, but an old list is not acceptable because this is current home meds. All right. And the source document for all of this is the current emergency department record. Okay. Inclusion guidelines just give you some idea. Suggested data sources, excuse me, just gives you some idea. It's always the emergency department record and a transfer summary if you have such, but any piece of the record that's considered a part of that current emergency department record is a source. And then we're talking about any current meds, over the counter, prescription, whatever. Okay, and just stop me if you have questions. Allergies and or reactions. Okay, does the medical record documentation indicate that the patient's allergy history was sent? Okay. Yes, if there's documentation it was sent, or if it says allergies unknown, that's fine. And again, I mean, we want it current, not old information, because since the last time the patient was at the hospital, maybe they developed an allergy. So food allergies or reactions, either or, as far as actions or allergies or reactions, medications, any other allergies or reactions. Okay, and no known allergies, that's documentation of allergies, and that's a yes. Meds administered in the ED. So does the medical record documentation indicate that the list of meds administered in the ED was sent to the receiving facility? Yes, if there's documentation it was sent. No, if there's no documentation it was sent. And the NA would be if there were no medications were given. Okay, so this one has the NA option. If no meds were given in the ED, then there doesn't need to be any documentation around that. So again, source document is anywhere in the ED record. ED provider note. Okay, this is where there seems to be a lot of, I don't want to say confusion, maybe misunderstanding, or maybe this is just really tied to the EHR, okay? But let me say there's nothing in here that says the note has to be signed. There's nothing in here talking about a complete note, okay? It does say the note must include at a minimum the reason for the current encounter, history of the present illness or condition, a focused physical exam around the condition, and any relevant chronic conditions if the patient has any. It needs to include this at a minimum, but it doesn't say it has to be signed. Okay, so but now this is where everybody's EHR gets tied in and everybody's is different. So the question that Veronica had, it's not about it being signed. It's about that a note by the provider, okay, and in this case, we mean it has to be the physician, the APN or the PA, a note with this information at a minimum, that there's documentation that is getting to the receiving facility within 60 minutes. Okay. So if we were talking about handwritten notes, if they wrote a handwritten note and that got sent, that would be good enough. And maybe they have a dictated note at a later date. That's okay, as long as the note that is within 60 minutes has this information. Okay, but from having discussions with people lately about EDTC, a lot of it seems like the time, pardon me, the timing is tied into that signature. So I can't answer for you other than to say, okay, again, we need a note by the provider with this information, the minimum information, getting there within 60 minutes or immediately available in the EHR. So this is another one where you as an abstractor might have to look into, okay, what does this mean? Or what is available in a shared EHR if it's not signed yet? Okay, I'm just kind of throwing out things, and if people have suggestions, feel free, but I can't really help you with that because, again, everybody's system is a little bit different. I can only tell you this is what we need within the 60 minutes or immediately available in the shared EHR. But a signature itself is not required for this. So Veronica, did I make things worse or kind of answer your question, or?
No, you answered my question. Thank you.
Mm-hmm. Anybody else? And if somebody doesn't feel comfortable talking or putting in the chat, you know, you can always get a hold of me after, but I know this has been an issue for a lot of people, and I don't want people to be falling down on this measure because it's not quote unquote signed. But if the signature is tied to being able to know the timing around this, then that might be a different story. Okay. I wish I could be more helpful, but this is really one where you've got to look, okay, what are we thinking about? What does sent mean? And what do we need in that note? Okay, there's a question in the chat. If we transfer out to a facility more than 60 minutes away, sent with EMS fax documentation must be documented. Okay, if you're going, if this is going with, okay, how do I want to say it? If you're sending the patient to a facility that's more than 60 minutes away, and this data isn't going with them, you are sending it, faxing it, it's got to be documented that it was faxed within 60 minutes of the patient's leaving your facility. And if I'm not answering your question, Mary, let me know. Okay, any other questions on the provider note? Okay, Jody, if you kind of monitor the chat again for me. Mental status orientation assessment. Okay, so does the medical record documentation indicate that a mental status orientation assessment was completed and sent to the receiving facility? Yes, there's documentation. No, there's no documentation. What we're looking for what's acceptable to be called a mental status or an orientation assessment, some of the phrases you might see as patient is alert and oriented. If the patient's comatose, if they're confused, if they're unresponsive, any of that kind of documentation would be acceptable for this, provided that it was sent, of course. If they do any kind of, if they do a Glasgow coma scale or any kind of coma or stroke scale, any kind of status or documentation around the patient's mental status or being oriented. Okay, and this doesn't say it has to be done by the provider. So, you know, a scale or any of that could be documented by the nurse. Any of this, that's acceptable documentation. So ED department record, transfer summary as always. or any kind of scale or flow sheets are acceptable.
Robin, we have a question in chat.
Okay. What if the location is like 6 hours away? Do we have that 6 hours to get that information to the facility? No, and that would make sense, but no, we didn't set it up this way. It's like if the information is going with the patient, then it has for as ever long as it takes. But if the information is being faxed or communicated, we still ask that it be done within 60 minutes. Okay, reason for transfer and plan or plan of care. Okay, so does the medical record documentation indicate that a reason for transfer and or plan of care was identified by the physician, advanced practice nurse, or physician's assistant? So here we are saying we want provider documentation around that. Did I miss something in the chat? So we agree if the documents go with, we are good. Yeah, if there's documentation, there still needs to be documentation in the record saying that that the record was copied and sent with the patient, or whatever was copied and sent with the patient there has to be documentation in the record saying that, and that the data elements we're looking for are on there. I mean, if you say entire record copied and sent with the patient, then it would just be a question of making sure the data elements were in the entire record. If you say transfer summary sent with the record, then you got to look at the transfer summary and see if the data elements are on there. Okay, so it's all about documentation saying what went with the patient, and then making sure the data elements we're looking for are in whatever documentation was transferred and went with the patient. And let me know if I'm not answering. Okay, excuse me. Reasons for transfer and plan of care has to be done by the provider. We're looking for provider documentation. So was there documentation of the reason for the transfer and or the plan of care? Was it sent to the receiving facility? So may include suggestions for care to be received at the receiving facility. Okay, reasons for transfer are almost always documented for transfers to acute care. Like, why are you transferring them to another facility? Have services that you don't provide. They need surgery, they need whatever. The reason for the transfer. The plan of care. So is the plan of care that they contact their provider next week or have an appointment with so-and-so next week? The plan of care. That can kind of be the plan of care, especially if the patient is going to an other healthcare facility. You might see more a plan of care rather than the reason for the transfer. Okay, but it has to be one or the other, has to be documented by the provider. Tests and or procedures performed. Okay, were any tests and procedures done in the ED? Was there documentation in that sent to the facility that any tests or procedures were done? So yes, no, and then not applicable if no tests or procedures were done. So were any labs done, any x-rays, any kind of procedures? Was there documentation that those procedures were done? Okay, I think this one is pretty clear. This is the one that seems, maybe it's not clear, but I don't know about the hard and fast of how people follow it, and that they should. So these are results, tests and or procedure results. Does the medical record documentation indicate that results were sent from completed tests and procedures? Yes, if there's documentation of results being either sent with the patient or communicated to the receiving facility when available. No, if there's no documentation, and then again, it would be an NA if no tests or procedures were done. So if you have a shared EHR, then we make it a given that those tests and procedure results would be considered sent. Now you have no say as to whether anybody on that receiving end is going to look at them, but that's, we can't take it that far. It's just that if you have a shared EHR, then we're saying that those test and procedure results would be considered sent. They would be available. Okay. If you've got tests or procedures that were not done at the time that the patient left, okay, and you don't share an EHR, then there has to be documentation that includes a plan to communicate the results to select yes. So if the documentation says culture results will be called when available, that's a plan to communicate. Okay. If there's no plan to communicate, then it's no. Okay. The fact that your facility does not communicate results that are negative is not a plan. Okay. I mean, unless you have that in your record saying, you know, we're only going to call you if the result is positive. I mean, you can't, it's not what your procedure is. There's got to be documentation in what's sent to the facility as to how they will get results of the tests that were done. Okay. And I'm not saying that this is an easy thing to have or a simple thing to add, but, and again, we don't have any say of if somebody's going to look at them, or, you know, maybe by the time the results are sent, maybe that patient isn't there anymore, but I don't know that you know that. So you need to have information in what's going to the facility, how results of tests that are not done yet will get there. Okay, does everybody understand what I'm saying there? Because it just seems like a lot of people are always really good at this, and I wonder how good people really are at this. Not that I'm doubting, but, you know, just throwing it out there. Okay. And this is one where we have to, you know, I mean, maybe it sounds like sometimes we're being way too punitive or picky, but in this instance, this is where we have to say, if you have an EHR, we're saying that those are going to be available. All right. And those are the data elements. The rest of this manual, there is a paper tool in case, you know, people like to fill out a paper tool rather than put it right in that Excel tool that we have available. But knowing that Excel tool is the one that gives you the numbers and the values that you need to put in to the MHA portal that Pat showed us. But here's a paper tool. And then this hasn't been updated for a while, you guys, so I don't know maybe how much this actually meets with the promoting interoperability requirements. So I don't want to address much about that. But any questions about the population or the data elements? This is your chance. I hope I didn't mess up people with the provider note, but we're really just honestly finding out, you know, how much an issue it might be around the signature. And again, it's hard to come out with a blanket statement because everybody's system is so different. I mean, even if you have Epic and you have Epic and you have Epic, it's a little bit of a different version of Epic because you might have the Epic from a bigger hospital that you've, you know, joined with for that, or are sharing their system with that. So Epic at one place doesn't necessarily mean Epic at another place. I don't see anything in the chat. Any questions? You can unmute yourself and ask. I don't know. I always think, is it good that there's no questions, that I really explain things great, or everybody just already knows, so that's good? Okay. Well, kind of as a wrap up, Jody will, I mean, usually, you know, back when we did trainings, oh, okay. Is there some chat now? let's see, we include on our nursing transfer note a statement saying all pending testing, results will be, I'm playing with my mouse again, sorry. We include on our nursing transfer note a statement saying all pending test results will be faxed and are called to the receiving facility once they are finalized. Yes. Okay. That is okay. All right. Because it's on, it's on your nursing transfer note. So if there's documentation that the nursing transfer note gets sent to that facility, okay, a statement saying that all pending test results will be faxed and are called once they're finalized. Yes. It doesn't, I want this to come out right. So it doesn't have to be more difficult than that. That is perfect. That's saying when the results are finalized, they will be called or faxed. Yep. And as long as your nursing transfer note, there's some documentation saying that nursing transfer note is being sent. Yep, that's great. Okay, thanks you guys for that. Okay, so, and this was kind of fast, but there's only just a few measures. So there's not really like a lot to say, but want to make sure that everybody really understands. Because, when we did this in person, I could see your faces and I could know if people might be saying they understanding, but their faces showing me something else. So what we're going to do a little different is there's a little quiz that if anybody's looked at the MBQIP monthly that came out this week, I did an EDTC quiz in there. And MBQIP monthly goes to everybody, but this is for you guys. I would like you all to do that. And what we're going to do is either later this afternoon or tomorrow, Jody's going to send everybody, who is on this. You're going to get an email that will have an evaluation and a certificate. I mean, I know it was just an hour long, but we'll give you a certificate in case you need it for any CE credits. And in the body of the email, we're going to put the quiz. Okay. So what I want is for everybody to highlight your answers to the quiz and send it back to us. Because I want to make sure that everybody, it's a good test for me to make sure that I covered the things I want to cover and that it came across in a way that people could understand. So I will be expecting, I think we have 27. At one point we had 30 people in the call. So I want 30 quizzes back. Even if you don't do this abstraction, answer the quiz. You listen to this for a reason. Make sure that you're understanding what we talked about. Okay. There's only 10 questions. And I would like it back within a week. So by next Thursday. All right. And then you'll hear from me. You can just send it back to Jody. Jody will send out the email. Jody's the one that technically knows how to send the emails to everybody way easier than me. But Jody will send the information to me. I'll be checking it out. And then you'll hear from me. So everybody who does the quiz will hear back from me, either saying, hey, great, yep, seems like you understand, have any other questions, or if you got something maybe wrong or didn't answer it, pick the wrong option, we'll discuss it. Because we want to make sure that we're really working on these EDTC measures. We would really like everybody to, we don't want you to be maybe looking worse than you are on the measure when it's a not understanding on some of the data elements. And granted, you shouldn't be looking better than you are if you're not collecting something right. So we're really working on this. And that's the one way that we can tell if there's an understanding of how to do it correctly is coming across. So anybody have any questions about that? Again, look for an email from Jody. And we appreciate you filling out the evaluation just because it helps me know, is she talking too fast? Is she not talking enough about things? It makes the next, helps to make the next section better. But again, if we don't get a quiz back from you within a week, you'll hear from me. Jody, anything I'm forgetting to say?
Oh, I think you got it all, Robin.
Okay, then I think we have, next week is a free week, but then the week after that, we have our training on the outpatient CMS measures. And then the week after that is a training on how to use a CART tool and a little bit of explanation on hospital quality reporting and HARP, the CMS reporting. So sign up for those if you're interested. And just, we got a couple more minutes in case anybody has any questions. Otherwise, you get maybe 3 whole minutes back. Last call for anything in the chat, or again, unmute yourself and talk if you want. And okay, this is where I should stop share for this. And then give me a minute. Let me figure it out. There. Can you see my contact information?
We can.
Almost forgot. Jody made this up for me yesterday. So again, this is contact me if you don't feel free to, you don't like to talk on the presentation, but you know how to contact me, and here's Jody's information. She will always forward it on to me. And thank you everyone for attending, and we'll be looking for your quizzes. So have a good rest of the day. Bye-bye.